Welcome everyone. Good afternoon. I'm Ranjit Kaur and I am the president of Breast Cancer Welfare Association Malaysia. And today we have a very interesting talk. And I know that more than 100 people have registered for it. So please do pay attention, turn off your camera, turn off your speaker so that you can hear what the doctor is saying. We have the doctor speaking today is Dr. Patricia Gomez. She is a consultant breast surgeon and she is the board member of BCWA. She is going to speak on more to do with how we go through breast cancer treatment and what are the issues that we face. So this is a consultation session with the doctor and meet the expert session. Dr. Pat Gomez will speak for half the session. And then after that, there will be a Q&A session. Please do write down your questions in the chat box and she will take all your questions and answer them. So over to you, Dr. Pat, and welcome to the session.
Thank you very much, Ranjit. And I hope all of you can see the slides. And if you have a problem with the slides, please let the moderator know so that we can do something to help you. Today we're going to talk about breast cancer, my diagnosis and treatment. Whenever I start, I always like to tell a story. And this is a very famous painting done by the Dutch master Rembrandt in 1654. And whenever he used to paint, he used to use his mistress, a lady by the name of Hendrickie, as the model for his paintings. And history tells us that Hendrickie died very young of unknown causes. But if you look very closely at her left breast, you'll see that the left breast is a bit abnormal, okay? It's literally out of shape, and you can actually even see some lymph nodes under the armpit. And we believe that Hendrickie must have died of breast cancer. And breast cancer has been around for a very, very long time. So breast cancer is the #1 cancer killer of women in Malaysia. And if you look at the incidence around the world, in the US and the United Kingdom, almost 1 in 8 or 1 in 9 women get breast cancer. And that's very, very high. In Malaysia boleh, so we are slowly getting there. In the 60s and 70s, it used to be 1 in 30, 1 in 40. And now at the present time, it is about 1 in 19. So what exactly is breast cancer? So if you look at the breast from the side view, these are the glands that produce milk, and each one has got a separate duct, saluran, if you would say, and that's how the milk comes out. And mostly cancer actually comes from the lining of the duct. And there is a process how it forms. Starts off as abnormal, and then as normal, and then it gets a little more abnormal. Finally, you get the precancer called ductal carcinoma in situ, where it is still within the duct. But very soon it will break out, and that's what cancer is. It invades into the normal tissue around it, and that's why we call it invasive ductal carcinoma. So it's actually uncontrolled growth of cells lining the breast ducts. What are the symptoms of breast cancer and what tests are done to diagnose breast cancer? For those of you who have already gone through treatment, you'll know most of this. But the symptoms are actually, the doctors would love to find it at this stage. No symptoms at all. The woman comes forward for mammogram and ultrasound screening, and it's found on screening. This is the best because we know it's going to be very, very early. Okay. Most of the time, however, it presents with a lump in the breast. So as I said, most of the time it's a lump in the breast or under the armpit, because you know the lymph nodes are under the armpit. Sometimes you can see retraction of the nipple. The nipple gets pulled in. Very, very rarely we also can get blood discharge coming out from the nipple. But any changes to the normal breast actually need to be examined. Okay. I put pain right at the bottom because pain is usually not a symptom of breast cancer. Okay. It is less than 5% that the initial symptom is pain in the breast. This is a very unusual type of breast cancer called Paget's disease of the nipple, and it actually starts off like a rash. The only difference between this type of rash and eczema, which is the normal skin rashes that you get from allergies, is that this rash tends to eat up the nipple. You can see that the nipple is actually already missing from this lady. Yeah, right. So what type of investigations do we do? Normally there will be some form of imaging. Either usually the standard is a mammogram, okay, a mammography with an ultrasound, and these are the usual tools we use to look at the features of the breast. Very rarely we use MRI. We don't really use MRI for screening. It's very rarely used when sometimes we want to rule out that the cancer is in more than one place. And then, of course, you will have a biopsy. So a biopsy means taking some tissue from the lump to check under the microscope and see whether this is a pre-cancer or a cancer. Please remember there is no blood test for breast cancer. Okay, the tumor markers that we do usually should not be done for normal people. We actually use them more for patients who already have cancer, and we want to monitor them. So the tumor markers that we use are not diagnostic of breast cancer. We use them more for monitoring. So of course, all of you would have been through a mammogram, and when you do a mammogram, it's a little bit of a discomfort. It's not really painful. If done properly, it's not painful. And what we're looking for are, of course, lumps in the breast. And you can see typically this is a cancer, and you can see that it is a spiculated margin. That means it is growing out, and that's why you see these little like a sunburst appearance, right? But actually what we want to find is it at this stage. You can see here the patient has got multiple small little dots of calcium, what we call microcalcification, and this is actually the first warning sign of cancer. Most of the time when we find these little microcalcification clusters, it's actually at the DCIS stage. Okay, it's at the pre-cancer stage, and you can normally see these microcalcifications almost 2 years before you actually feel a lump in the breast. Yeah. Okay. So this is why we keep telling women to please come forward for mammogram screening every 2 years at least. So the diagnosis, when we make a diagnosis of breast cancer, of course, the doctor will examine you. You then go for some form of imaging and then a biopsy, histopathology, so that we know the type of cancer we're dealing with. Now, what are the treatments of breast cancer? So the treatment depends entirely on the stage of the disease, okay? And breast cancer, as you know, goes from stage 0, which is the pre-cancer, and then stage 1 and 2, early cancers, stage 3 and 4, late cancers, but still treatable. The staging involves actually the size of the tumor, whether it's involving any local involvement, whether it's stuck down to the skin or the muscle underneath, and then whether it has spread to the lymph nodes or spread to other organs, what we call metastasis, when it has gone to other areas. Yeah. So what exactly is an early breast cancer? An early breast cancer, believe it or not, is a tumor that is less than 5 centimeters. 5 centimeters is probably about the size of a small egg. So sometimes it's not about the fact that you haven't checked your breasts. It's because some women are in denial and they come with late cancers because unfortunately the cancer doesn't have any pain, and therefore they think that because there's no pain, it cannot be anything serious. But any lump in the breast must be examined. Okay, so an early cancer is less than 5 centimeters. It doesn't involve the skin. It's not stuck down to the skin or the muscle underneath. Even if there are lymph nodes, they're less than 4. And it hasn't metastasized. It hasn't run to any other organs like the lung or the liver. A late breast cancer, as you can see here, is bigger than 5 centimeters. It involves the skin. So here the nipple is retracted. The nipple is pulled in. So obviously the skin is involved. And it may be stuck down to the muscle underneath. There may be many lymph nodes under the armpit, and they may be large. And it may have metastasized to different places. So that's a late breast cancer. Treatment is divided into 2 types of treatments. Loco-regional treatment, what we do for the breast and the armpit, the lymph nodes in the armpit, and then systemic treatment, treatment that involves the whole body, treating the whole body. So loco-regional is usually surgery and radiotherapy. Systemic, of course, is chemotherapy, hormonal therapy, and the newer targeted gene therapies. Yeah. The primary therapy for breast cancer until today is still surgery. You need to take the cancer out. And then you have what we call adjuvant therapy. Adjuvant means add-on therapy. And these therapies are usually used to make sure that the cancer doesn't come back again. Of course, foremost is chemotherapy, followed by radiotherapy. You can also use hormones or anti-hormone therapy. And as I said, the newer targeted immunotherapies. Occasionally, women are subjected to neoadjuvant therapy. Now, neoadjuvant therapy means we give one of these therapies as the first line because either we are trying to shrink the cancer so that we can save the breast, we can do breast conserving surgery, or sometimes because the cancer is a very aggressive cancer and therefore we want to treat the whole body and make sure that the cancer does not spread beyond the breast and the axilla so that the patient has a better outcome. When we talk about surgery, surgery is two types. You can do breast conserving surgery, which is what we call a lumpectomy, or the newer term is oncoplastic surgery. And you can also have mastectomy. Mastectomy, of course, means removing the whole breast. Nowadays, of course, we do mastectomies, but we can also offer immediate reconstruction. That means making a new breast for you at the primary stage. That means when you're having the surgery for mastectomy, you also have the recon. So you go into the OT with a breast. When you come out, there's also a breast. Now, there are various ways that we can do it. Sometimes we use the Latissmus Dorsi flap with an implant. This is the muscle from the back. Or we can use the muscle from the tummy, okay, which is called a TRAM flap, or transverse rectus abdominis muscle flap. In the armpit or axilla, we usually will sample the lymph nodes. Nowadays, we do sentinel lymph node biopsies. And if the sentinel lymph node is involved, we usually follow up with an axillary clearance, which just means removing a few more lymph nodes from under the armpit. How do we make the decision about whether you go for a mastectomy versus breast conserving surgery? So usually in early breast cancers, we are always able to offer breast conserving, that is stage 1 and stage 2, but we usually have an upper limit of about 4 centimeters. This is arbitrary. Basically, you've got to have enough tissue in the breast to have a good cosmetic outcome. So it's the size of the lump versus the size of the breast. And most of the time, with Asian women, unfortunately, the breast size may be very small. So even with a 2 centimeter or 3 centimeter, sometimes we cannot offer breast conserving. We end up doing mastectomies and reconstructions. Okay. Whenever you do breast conserving surgery, you need to combine this with radiotherapy. This is to protect the rest of the breast in case you have other cells there that are not so good. And then the outcome is similar to mastectomy. So breast conserving surgery has to be combined with radiotherapy, and then the outcome is the same as mastectomy. So mastectomy are usually for later cancers, advanced stage, stage 3 and stage 4, or if the cancers are multifocal in more than one place. Okay, so sometimes you will end up having to do mastectomy if they have multifocal cancers. The relative contraindications for breast conserving where you end up doing mastectomy is sometimes central tumors, cancers that are underneath the nipple. If you remember the first drawing of the cross section of the breast, you'll find that all the ducts open at the nipple. So sometimes you may not be able to save the breast because all the ducts around the nipple are involved with the tumor. Sometimes once you've given chemotherapy and the cancer has shrunk but not shrunk adequately, you still end up doing a mastectomy. Or sometimes if you have precancer and the precancer is extensive in the breast, involving a lot of areas, then again, you may need to do a mastectomy. This is an example of a breast conserving surgery where you've removed the lump and the scar is there for the lump and another scar underneath the armpit for the lymph nodes. Here again, this is after radiotherapy, and you can see that the breast actually looks almost normal. That's the scar for taking out the lump, and that's the scar for taking out the lymph nodes in the armpit. So you're able to give very good cosmesis with breast conserving surgery and the present oncoplastic techniques. The advantage, of course, of having a mastectomy over breast conserving is that the risk of a recurrent cancer in that breast is minimized. So if there is a recurrence, there is a very, very slight incidence of increased recurrence with breast conserving. But as I said, this is not so obvious if you have had radiotherapy as well. So if you want to avoid radiotherapy to the chest, then maybe a mastectomy is better. This does not, of course, exclude the fact that you can still get skin recurrence on the chest wall after a mastectomy. So if the cancer was very, very large, sometimes you can even get skin recurrence after a mastectomy. So there are different options available for breast reconstruction. You can either use implants, expanders, flaps, as I mentioned before. The reconstruction after the mastectomy can either be done at the time of surgery, what we call immediate reconstruction, primary reconstruction, or at a later date. You can pick your time and do it 6 months later, or 6 years later, or even 10 or 15 years later if you so decide. So we can still do a delayed reconstruction for you at a much later date. The disadvantage of a mastectomy over breast conserving is, of course, more tissue has to be imported from a different place to make a new breast for you. So this is a typical example of a mastectomy. Okay, so the lady has had her breast removed and the lymph nodes removed from the axilla through this scar. And after operation, of course, she's wearing an external prosthesis. This silicone prosthesis fits in a cup, in a special pocket in the bra, okay? And therefore, from outside, of course, she looks absolutely normal, yeah? But the better option for this, of course, is doing a reconstruction. So as I said, you can either do a one-stage, a primary, or a delayed, and we use implants and flaps. The simplest type of reconstruction is just putting a saline or a silicone implant underneath the muscle. This is the same implant that we use to make the breasts bigger. For those who want enhancement of the breast size, we use the same implants, yeah? And we usually put it under the muscle, and you have various types now that are very, very cosmetically almost similar to the normal breast shape. This is an example of a lady who's had just a simple implant. You can see that was the scar from the original mastectomy, and that's a reconstructed nipple as well. So she does have a very good cosmetic outcome. We can also use flaps. That means using the patient's own tissue to create a new breast. So the various areas that we take the flaps from are from Latissmus dorsi, the back, from the tummy, and sometimes from the back, from the gluteus as well. But it's very, very rarely used here. So this is how we do Latissmus dorsi. There's a huge muscle at the back called the Latissmus dorsi. So we take some skin and the muscle, swing it around in front. We put an implant behind it to get the proper size, and then the scar is very nice behind. So this skin here is actually from the back, and behind the skin there's a little bit of muscle, and then the implant, yeah? And she's still under construction because the nipple hasn't been done yet, okay? This is a reconstructed Latissmus dorsi with reconstructed nipple as well, and you can see she's got very, very good cosmetic outcome, yeah? TRAM flap, on the other hand, is using, so you've got two muscles down in the tummy called the rectus abdominis. These are the muscles that men, when they are in a good shape, call the six-pack muscles, okay? And we use half of this muscle, one side of it, to create a new breast. And usually we take all the fat from the tummy as well, and the scar at the bottom is like the scar for a Caesar, yeah? When you've had a delivery or a cesarean section, it's the same sort of scar that we use. So we use all that fat to create, and the skin to create a new breast. So it's a lovely operation because you buy one, you get one free. Not only do you get a new breast, you also get a nice tummy tuck. So yes, so that's the scar at the bottom, yeah, and a reconstructed nipple as well. That's another example. This is actually a free flap where we've taken one of the blood vessels and attached it, so the scar at the bottom is also almost similar to what you saw before, yeah, okay. And as I said, we can also reconstruct the nipple, okay. We normally create the nipple itself from the skin, and then we tattoo in the areola. So most of the doctors are now becoming tattoo artists as well, yeah, okay. With the armpit and the lymph nodes, what we usually do is we've gone away from doing taking out too many lymph nodes, because this, of course, will increase the incidence of lymphedema or swelling of the arm. So nowadays what we do is what we call a sentinel lymph node biopsy. And this, of course, is only for early cancers. What we do is at the time of surgery, we inject some blue dye and sometimes some radioactive material. And this dye will be carried towards the first draining lymph node. And that's called the sentinel lymph node, like a security guard. So what we do is we sample this lymph node, we send it for frozen section. Frozen section means while you're sleeping on the operating table, this lymph node will go to the lab. They will freeze it in liquid nitrogen, make sections of the lymph node, look under the microscope and tell us whether this lymph node has got cancer in it. And the theory is that if this lymph node is clear and doesn't have cancer cells, in all likelihood, all the other lymph nodes will be free as well. Okay, so sentinel lymph node biopsy. If this lymph node has got cancer in it, then we will proceed with a clearance. And an axillary clearance just means removing a few more lymph nodes from the armpit, from the axilla. Yeah. This is the most important part of the cancer report, and this is the histopathology report after surgery. And this is what tells us, number one, your stage of cancer. Number two, the type of cancer or the face of the cancer that we're looking at and how to treat it. So we have gone away from using blunderbuss therapies where we give chemotherapy to hit everything in sight. Now we are making it more personalized. So the first thing that the histopathology report will tell you is the type of cancer. Is it just a precancer? Is it ductal carcinoma in situ only? Is it an invasive ductal carcinoma coming from the milk ducts? Is it actually coming from the lobules? So you have also cancers that arise from the milk gland itself, and that's called an invasive lobular carcinoma. Is it a phylloides? This is a completely different type of cancer, yeah? Malignant phylloides. So looking at the first report, this is what we want to know, the type of cancer. Then the report will tell us the actual size of the cancer. So the pathologist will sit and measure the cancer in centimeters, and depending on that, you can have the size going from 0, where there's no cancer there, or up to 4, where it's involving the skin and the muscle. They then will count all the lymph nodes that we send them, okay? And they'll tell us about the lymph node status. Again, you know, N0 means none of the lymph nodes were involved, and N3 is when they are large, very large, and multiple lymph nodes in the armpit, yeah? Metastasis, this is usually seen with a CT scan or a PET scan, and it can either be 0 or 1, no metastasis, or it has traveled to other places. What's more important nowadays is that we look at the immunohistochemistry of the cancer. And this means that we are looking at the actual face of the cancer. And the things that we look for are the estrogen receptor. So estrogen and progesterone are two of the hormones that women have. And some of the cancers actually produce the receptors for these hormones, which means that if your cancer is ER/PR positive, it's got the estrogen and progesterone receptors. That means that if you supply hormones to these type of cancers, they can grow back. And therefore, one of the types of treatments that you will get will be to block the hormones or use an anti-hormone, okay? The next thing we look at is we're looking for this gene, the HER2 gene. Now, this gene is not something that is inherited from your parents or passed down through the family line, okay? This is actually a protein that is made by the cancer. So the cancer is actually got this gene in it, and it helps the cancer to grow. So it helps in the growth and spread of the cancer. So this is a particular thing that we look for, because we also have a treatment that blocks this gene. And those are what we call the targeted therapies. This last one is basically the MIB1 status, or the Ki67 status, is what tells us how aggressive your cancer is. It usually goes in a percentage from 0 to 100%, and it gives us an idea about how active or how aggressive your cancer is, okay? So all this will then tell us the stage of your cancer, anywhere from 0 to 4. And depending on that, you will then have treatments. Now, when we look at all the features of the cancer and decide on your stage, it's from these features that we will then decide the types of treatments that you will get. So when we look at the features, okay, you have features that are good, that means a so-called good type of cancer, or features that are not so good. Okay, so a lobular carcinoma a cancer coming from the milk ducts, is actually a cancer that's not so aggressive. Unfortunately, this lobular carcinoma tends to be multifocal in more than one place, that means, and it can sometimes 10% can be bilateral. So although it's a good cancer, it, as usual, comes with some side effects, multifocal and bilateral. The ductal carcinoma is the one we see most of, okay, and this is slightly more aggressive than the lobular carcinoma. We then look at the size. Again, size tells us the stage. So less than 5 centimeters is always good. More than 5 centimeters, it becomes a stage 3. We look at the grade. Now, grade means how fast the cancer is growing. And we can see this from the pathology because you can see cells dividing, okay, or in the process of dividing, what we call mitosis. And from counting the mitosis and the features of the cells under the microscope, we can tell whether the cancer is growing aggressively or not. So we have 3 grades. Grade 1 is very slow growing. Grade 2 is faster. Grade 3 is an aggressive cancer that is growing fast. Okay. Lymph nodes, as I said, less than 3 lymph nodes is still good because it means you're early stage. More than 3 lymph nodes, you become stage 3 and above. Then the ER and PR status, your estrogen and progesterone receptor status. If it's positive, it's good, because basically you just have to think if the cancer's got time to make other things, to make things like the ER and PR, the receptors, then obviously it's not just growing, it's doing other things besides growing, and therefore it's a slightly less aggressive cancer. And of course, because we have anti-hormone therapies for ER/PR positive cancers, that it's a little bit better. So the negative, if you're ER/PR negative, it usually means that you're going to get chemotherapy because this is a slightly more aggressive cancer. Then we look at the HER2 gene. The HER2 gene, if it's negative, it's good. Okay, if it's positive, not so good, but it means you will need chemotherapy plus the targeted therapy, which is Herceptin. Okay, looking again at the Ki67 and the MIB1, if it's less than 30%, this is a cancer that's not growing aggressively. More than 30%, it is a slightly more aggressive cancer. When the surgery is done, the margins should be clear. There shouldn't be any cancer cells left behind. If there are, if your margins are involved, it usually means that you may need a little more surgery, or it may mean from a breast conserving surgery, you may end up with a mastectomy. The other thing we look at is lymphatic and vascular permeation. Now, what this means is that the cancer has the ability to break in through the lymphatic channels and the vascular channels. Okay, and if we see that under the microscope, okay, that's not so good because it means the cancer cells are starting to spread. Okay, are starting to spread if we see cancer cells within the lymphatic channels and vascular channels. Okay. So all this would show a stage 1 and 2 to be early cancers, good prognosis, not so good stage 3 and 4. Okay. Then the treatments also depend on the type of IHC that we see. And from this, we have identified 4 different types of cancer and the way that they actually progress. Yeah, progress. This is actually looking at the genes of the cancer. Okay, so they have studied the genes of various cancers and they have come up with 4 different types of cancers. Okay, and you can see here they are called luminal A. Luminal A is where your estrogen and progesterone receptors are positive and your HER2 receptor is negative. Luminal B, the ER and PR are also positive, or one may be positive, one may be negative. but your HER2 is also positive. So this is what we call a triple positive cancer, okay? Then you have those that are HER2 enriched, which means your ER and PR are negative, but the HER2 is positive, okay? And then you have the dreaded triple negative. So triple negative is a very aggressive cancer. It has a not so good outcome. And here the ER, the PR, and the HER2 are all negative. So looking at these features above, you can tell that a luminal A cancer is a less aggressive type of cancer with better prognosis, better outcome. Luminal B is not as good as a luminal A, but still pretty okay. The HER2 positive one, the HER2 enriched, is a little bit more aggressive. And then you have the triple negative, which is a slightly more aggressive. We usually call this a basal type of cancer, more aggressive with a not so good prognosis, not so good outcome. But the most important thing is still the stage of the cancer. This is what really will determine your outcome. So, of course, looking at the 5-year, in fact, now we look at 10-year survival because breast cancer patients live well beyond 5 years now, and we're looking at 10-year survival rates. And you can see that if you come with pre-cancer, of course, you know it's non-lethal. Okay, it's non-lethal. It's critical, and therefore you will outlive that. But even in stage 1, if you do the proper treatments at 5 years, 98% of women are still well and doing well, even at 10 years. Okay, stage 2 slightly lower. Stage 3 and stage 4 do not have such a good outcome, but nowadays with better and better treatments, even the stage 3 and stage 4, even stage 4 can sometimes, occasionally, I've had quite a few patients with stage 4 disease that have lived longer than 10 years. Okay, it just depends where the cancer goes. Yeah. Okay. Now, as I talked about genes earlier, this is not to be confused with the genes that are inherited. Okay. Now, these are all the Angelina Jolie genes. Okay. So breast cancer, there are 15 or more tumor suppressor mutations in the genes. Now, these are the inherited breast cancer genes. The commonest ones that we know are called the BRCA1 and BRCA2, and these account for almost 80% of all the inherited cancers that we see. So we see them in certain ethnic groups, like the Akazani Jews, which is the type of ethnic group that Angelina Jolie comes from. But there are many other tumor suppressor gene mutations that we can detect as well from just doing a simple cheek swab or a blood test. Okay. But with BRCA1 and BRCA2, we know what the outcomes are or the risks are. But with all the others, it's very difficult to calculate the risk, except in very few. So you can see here from the diagram here, BRCA1 and BRCA2 account for almost 80%, 70 to 80% of the gene, the inherited genes that we see. And then there are all these others. And these tests, as I said, can be done as a simple cheek swab or a blood test. Okay. And the one that we see quite common here in Malaysia is the PALB2. Quite common among the Chinese population, and it can come either from the father or the mother's genetic line. Yeah. Okay. And of course, having these genes means that actually your risk for breast cancer is very, very high, especially BRCA1, BRCA2. Not only breast cancer, also ovarian cancer, and very rarely uterine cancer or womb cancer as well. So women, so if there is very strong family history of breast cancer, ovarian cancer, uterine cancer in your family, and you already have breast cancer, and you need to know whether you then need to know whether you are a gene carrier. So there's a very, very good association called an NGO actually that's called Cancer Research Malaysia. And you can actually Google them. Their office is in Subang Jaya and Subang Jaya Medical Center. And they are actually studying the genes of Malaysian women. And therefore, they offer these tests at a subsidized rate. You will have genetic counseling before that, of course. And then you will be able to get the gene test if they think that you are at a high risk. Okay. I mean, a note to say here is that if you're going to do the gene test, I think the implications of doing the gene test are very important, because you are then living in a if you happen to have the gene test, it's like living with a sword hanging over your head, because it means that you are high risk for getting breast cancer in the other breast, almost 83%. You are also at high risk of getting ovarian cancer, about 50%, and of course the uterine cancer lower. Okay, so when we come to treatments, okay, as I mentioned before, these are all the adjuvant treatments after surgery. You have chemotherapy, radiotherapy, hormonal therapy, targeted therapies or immunotherapies. We also have very good supportive therapies now. So the treatments of chemotherapy do not become so daunting now, because we have very good anti-emetics or anti-vomitings, medications. We have medications that can boost your cell count, push up your white cell count so you don't feel so tired and drained out, blood supplements, and even therapies for the bones. Okay, so even if you have bone metastasis, we have very, very good medications nowadays as supportive therapies. There are some tools on the internet and otherwise which will help you to decide about your therapy as well. So the first two are actually available online. Predict is actually available to anybody. You can put in if you look at your histopathology result and then put in all the features on the Predict, you're able to come out with a sort of a result that will tell you what your outcome is going to be, whether you do chemo or not. So it helps you also, it helps your doctor and you to make a decision together about whether you need chemotherapy or whether you can avoid chemotherapy. The more change ones, of course, are called Oncotype DX, Mama Print, or Prosignia. This is where we take the tissue. That means we take the genetic cells of, we take the genetics of your cancer and send it for checking, and it comes out with a risk score for recurrence. So it tells you whether your cancer has got low risk of recurrence, intermediate risk of recurrence, or high risk of recurrence. And of course, those who have high risk of recurrence are the ones that are going to need chemotherapy. Okay? So the important considerations for chemotherapy: when is it that your doctor will actually advise you to have chemotherapy? Looking at all the research that we have to date, the most common thing, of course, is going to be spread to the lymph nodes. If your cancer has already spread to the lymph nodes, then you definitely need chemotherapy. The theory behind this, of course, is that since the cancer has spread to the lymph nodes, and once it is in there, there is no scan in the world that can pick up one cell of cancer, okay? And therefore, if there are other cells in your body, in your lungs, in your liver, in your bone that the cancer has already spread to, because you're doing chemotherapy, and chemotherapy is given as an injection into the blood, and blood goes everywhere, we are hoping that the chemotherapy will kill the cancer cell wherever it is, okay? The next is that if you have a tumor that is growing very fast, if it is a grade 3 tumor, again, this is an indication to give you chemotherapy. A large size tumor, that means you have stage 3 or stage 4, again, is another consideration for chemotherapy. If it's involving the skin or muscle, as I said, a large size tumor. If you are ER/PR negative and we have lost the option of using the anti-hormone treatments for you, again, you will get chemotherapy. HER2 positive, you will get chemotherapy plus the targeted therapy, which is the Herceptin. If you have lymphatic or vascular infiltration, if we are seeing cancer cells on the pathology report inside the lymphatic channels or the blood vessels, again, usually you will get chemotherapy. Young age is very controversial, okay? Usually for those under 30, because they're getting cancer at a very, very young age, we usually will tend to give them chemotherapy. Basically, we are over-treating them because we do not have enough research behind us to really tell how to manage women who have cancer very young, okay? And therefore, we usually will over-treat them with chemotherapy because we want a very good long-term outcome for them. Again, if you have comorbid diseases, for example, if you have heart disease or you have hypertension or diabetes, your doctor has to decide very carefully with you what are the types of treatments that you can take, because chemotherapy long-term effect will always be on the heart. Same thing with the HER2 positive, the targeted therapies, they also have an effect on the heart, and therefore you may need a few more other tests like an echo, an ultrasound of the heart to decide whether you're fit enough to go through chemotherapy. Okay, so for the younger patients, yes, but even for the older patients and in the elderly, as far as I'm concerned, age is just a number. We have to look at you physically and see your ECOG status, as we call it, before we decide whether to give you chemotherapy or not. I have some women in their 70s, 75 and above, going through chemotherapy and doing very well as well. So age is not, it's just a number. We have to look at your actual physical status before we decide whether you do chemotherapy. Chemotherapy is not so scary as it was before. Okay, we have very good newer agents like the taxanes, which have improved survival enormously. Okay, and although they are much stronger drugs than the original anthracyclines and cyclophosphamide that we used, they actually have much less side effects. So stronger medicines with less side effects, good combination. Yeah, we can nowadays actually give oral chemotherapy as well, agents like Xeloda, and these actually improve the quality of life as well and prolong your survival. Okay, there are much better agents, newer agents to control the side effects of chemotherapy, like the GCSF for boosters, antiemetics, anti-vomiting, pain control, and for bone metastasis, very good drugs as well to keep the bone metastasis under control. There's a whole load of drugs that we use for hormonal therapy. The older time-tested one, of course, is tamoxifen or Novaldex. Okay, been around for more than 70 years now. 60 years. Okay, 60 years. And then we have other drugs that we can use to block the hormones as well. The new kids on the block are the aromatase inhibitors, but these are only for post-menopausal women. So women who have not attained the menopause yet will usually be given tamoxifen plus minus one of these. Those who are already menopause will be on the aromatase. There are three of them in the group, and one of them you'll be. We also have fulvestrant, which is an injection, which is taken monthly. And we now have what we call mTOR blockers, which actually enhance the effect of the hormone therapy. So they're usually given with the hormone therapy in metastatic or late cancers. And the newer ones are also the PARP inhibitors. Targeted therapy, as I spoke to you before about, trastuzumab is Herceptin. And it can be given in combination or separately with Perjeta, which is another form of targeted therapy. These are actually monoclonal antibodies. So they actually block the gene. They block the gene. It's an antibody to the gene and blocks the gene, and therefore the cancer cannot grow. You have lapatinib, which is also something like that. Kadcyla, which is trastuzumab combined with a chemotherapy. Affinito, everolimus, which is an mTOR blocker. I told you we use it with the hormone therapies to enhance the hormone therapy action. The newer ones are PARP inhibitors. Olaparib is one of these, and these are used especially now for those who are BRCA gene positive. So if you're a gene carrier, we now have new evidence that shows that olaparib in combination with your chemotherapy gives you a much, much better outcome. We also have CD4/6 inhibitors, and these again enhance the anti-hormone effects. And you also have Avastin, which is an angiogenic targeted therapy. It blocks the formation of new blood cells, and therefore the cancer cannot grow without new blood cells, and also helps with that action. Even with radiotherapy, we have newer types of treatments. The traditional one is giving external beam, usually 15 to 20 times, or fractions as we call them. And this is all image guided now. So we're not burning right through you. We're not burning your lung. We're not burning the wall behind you. We are planning and giving you the radiotherapy to only affect the breast that is involved. A newer kid on the block, of course, is intraoperative radiotherapy, where you only get a single dose at the time of surgery. And this is now available in most of the private hospitals, Pantai and SJMC, even University Hospital has this machine. And therefore, you only have the radiotherapy at the time of surgery, and you don't have to come every day for 15 or 20 days to the hospital for your radiotherapy. This, however, is only for very, very small early cancers, okay? And they've got to be good cancers as well. That means non-aggressive ones, those that are ER, PR positive and HER2 negative. So in conclusion, breast cancer treatments have now become very advanced, and we can now personalize the treatments. It gives you better prognosis, better outcome, better quality of life as well. So even though you go through the treatments, it's not so daunting, and better control of the cancer. Breast cancer is not a death sentence. The key is to detect it early. And that means encouraging women to go for mammograms and screening from the age of 40 onwards. But be very careful where you go for the mammogram. Make sure it's a very good center. Thank you very much. So we can take questions now if you.
Thank you.
Yeah.
I think this was a fantastic session. I can remember how archaic my treatment was 24 years ago, and how different it is today. There's so much to learn these days. Hi, doctor. Are there any dietary restrictions for breast cancer survivors? That is dairy products, yogurt, red meat, alcohol, etc.
Right. So very honestly, scientifically, there are no so-called pantangs or dietary restrictions, okay? For any cancers, for that matter. All the stuff you see on the internet about dairy products, sugar, has no scientific evidence. The only thing we have up to date is burnt animal fat. That means your chasiu and siu yok lah, unfortunately. Or the satay, the middle part that's nice and burnt, that always tastes the best. Yeah. We know that burnt animal fat can produce carcinogens, and carcinogens are things that can cause cancer, or that can turn your cells funny. And therefore, that's the only thing that we say that you can't have, but everything else is fine. I know one of the questions is going to be about soya, and it used to be that we said that those who have the ER/PR positive cancers cannot take too much of soya because it's a phytoestrogen, but that has actually been debunked. They've actually done the research in Australia, and we found out that soy actually protects your breast. And that's probably why Asian women don't have as much breast cancer as the Western women, because we do take a lot of soy in our diet. I would say everything in moderation, and that will get you through, I think.
Dr. Pat, coming back to satay and chasiu, if
Yep.
it is not the burnt part, I mean, the burnt,
Yes.
it's a bit like the charcoal, right?
Yes,
so if
correct.
it's not burnt, if it is not black in color, people can still eat it, right?
Yes, of course they can. Yes, it's just the burnt fat that causes the problems.
So we have a question from Fan Li Shang.
Yes.
What is the recommended duration for tamoxifen for stage 1? And if we have done, and the second question is, if we have done mastectomy, can the cancer metastasize?
Okay, so cancer metastasizes not because of what surgery you've done. Okay, if you've done, it all depends on the stage of your cancer right in the beginning. Breast cancer, unfortunately, is one of the sneaky ones, and therefore, even with a stage 1, the cancer can come back. Okay, especially if you have a triple negative breast cancer, it can come back. It can metastasize. It may not occur immediately. It may occur in the years to follow. But the most important thing is to do your treatments properly up front. And that is the thing that actually buys you time. Okay? About the duration of tamoxifen, even with stage 1, the recommendation now is for 10 years of hormone blockade. Now, everything I'm telling you comes from research. So because we have a new study that came out of San Antonio in the US, where they've actually followed women up for more than 20 to 25 years. So initially they have two groups. One has taken tamoxifen for 5 years and the other has taken tamoxifen for 10 years. And when they compare the results, they find that the women who had taken tamoxifen for 10 years actually had better outcome. They had less recurrence and less deaths in the group. And that's why now around the world, we're saying that if you have an ER/PR positive cancer, okay, I'm talking about invasive, then you need to take the hormone therapy for 10 years. If you have DCIS, ductal carcinoma in situ, or pre-cancer, then the recommendation is to take it for 5 years, okay? And this is again based on research that we've done. So the women who had DCIS and took it for 5 years versus those who took it for 10 years, there was no added benefit taking it for 10 years. Whereas those with cancer, taking it for 10 years made a definite difference between recurrence and mortality, yeah? Okay.
Is dementia one of the side effects of hormonal treatment?
So far as we know, dementia is not really, again, we don't have much research on that to tell you whether yes or no, but we do know that blocking hormones, that means once a woman becomes menopausal, okay, the risk is always there for dementia, because one of the things that estrogen does, it actually helps to protect the brain against some of the effects of dementia. That means the formation of these certain proteins in the brain that can bring on Alzheimer's. But at the end of the day, it's a toss-up between dying from the cancer or getting dementia. So I think everything has to be looked at, and if we find that the patient is starting to get early dementia, we may then curtail the treatment and say, okay, maybe at this point, after 7 or 8 years, you have to stop because you're becoming more and more forgetful. We find that actually chemotherapy does cause a lot of, not dementia, but a lot of memory loss. This, they traditionally call this chemo brain, but it is an actual thing that we see with chemotherapy. But nowadays we tell women who are undergoing chemotherapy that they must do word puzzles, Sudoku, to keep the connections in the brain going. And that's how you preserve your brain function. Even if you're not doing chemo, you're not taking any hormonal treatments, this is a very good thing to do, so that the connections in the brain remain longer, and therefore it wards off dementia.
Yeah, so thanks. I mean, now we call it oncobrain because they know that there might be other factors that come into play as well to cause the problem of memory loss or memory problems. How do we know that we are losing memory naturally and not because of the treatment?
Well, the best way is to look at your own parents. Dementia is usually hereditary, or we find it runs in families. And if your mom and dad have dementia or Alzheimer's, then it's a very good chance that you're going to get there too. But as I said, doing mental tests, mental sums, and Sudoku, things that keep the brain. You've got to be sociable. You've got to mix. You've got to have friends. You've got to have activities. You've basically got to have a purpose in life. Because if you don't, then you're going to go downhill anyway, no matter what anybody else does. May I know, I have right breast pain along with neck, shoulder, and back. Is it due to the hormone? So it depends on what hormone treatments you're taking. The aromatase inhibitors, that is Arimidex, Femara, and Aromasin, the side effect of that drug is on the bones. It causes osteoporosis, osteopenia first and then osteoporosis. That means the bones tend to get soft, and therefore these pains could be due to those hormone treatments if you're taking them. Tamoxifen actually protects the bones in some way, and therefore if you're on tamoxifen, it may not be the cause of your bone pain. It may be just muscular pain or something like that is causing your neck, shoulder, back pain. It sounds as if you're very stressed. So maybe it's stress. What we all need is a good massage, but unfortunately everything is closed. So we're going to have to wait until the spas open up again before we can have a good massage. Okay, there's another one here from Lucas.
Before that, there's another question before that.
Yeah, before
Given the
that.
current pandemic, how do we go about the schedule appointments, that is the yearly appointments?
Yeah, no problem with that. If you have your follow-up card, just show that to the policeman with the date that you're due for your follow-up, and you can come to the hospital. There's no problem with that. For medical reasons, even if you have to cross borders, you're allowed. My advice would be to go to the police station and get the permit to travel across borders. But within your borders, it's allowed if you're going for a medical checkup, your medical follow-up. All you need to do is show your hospital card with the date of that you're traveling.
In breast cancer, she's got breast cancer on both sides and has removed lymph nodes on both sides.
Okay.
Can you have the vaccine on the arm? Which side to jab? Any side effects other than arm? Can we vaccine on other parts?
You can actually take the vaccine anywhere because it's an intramuscular injection. So you can even have it on your buttocks, but I don't think you want to pull your trousers down in the middle of that huge place. If you're having it at Putra World Trade Center, I don't think you want to pull your trousers down, but you can probably ask the nurse. There is really no problem with taking your injection either on the right arm or left arm. Okay. The only thing you need to remember is that because you're taking the injection on the arm, your lymph nodes in the armpit can become slightly swollen. If you're going for your follow-up and you tell the doctor that you had your injection on that arm and that's why we're seeing lymph nodes there, then it's no problem at all. Okay, so it's still safe for you to take your injection on either arm, even though you've taken out your lymph nodes. You can get enlarged lymph nodes because of the injection, or if you so opt, you can have the injection on your buttocks as well. Not a problem.
How long after the second dose of vaccination can we go for ultrasound and mammogram?
You can actually do it the very next day. As I said, you just need to tell the doctor who is doing your ultrasound that you had your vaccine on that arm, and that's the probable reason. If they see any lymph nodes there, that's the probable reason for the lymph node enlargement because of the vaccine.
Can you explain more on the food that HER2 positive needs to avoid?
HER2 positive can eat everything. As I said before, there is no pantang or no restriction dietary wise for any cancers. Okay, everything that you read on the internet is fake news. Okay, there is no scientific evidence behind sugar or dairy products. So my advice to you is eat everything in moderation. Avoid burnt animal fat. So the charcoal burnt type of barbecue and stuff is not great. Well, you can even have that once in a way, but not very often, not every day. Yep.
I was recently diagnosed with triple positive, ER, PR, and HER2 positive. Now
Yeah.
undergoing chemotherapy. You mentioned
Okay.
that this is not of the genetic kind. Will my chemo address any potential genetic related cancer risk? Should I do the BRCA test? I think she.
Okay. So yeah. So your ER, PR, and HER2 has nothing to do with your BRCA gene. Okay. As I explained before, the ER, PR this is actually the like the face of your cancer. Okay, so you have a triple positive cancer, which means that we need to treat it with chemotherapy, with Herceptin, and with anti-hormone therapies. So these are the recommended treatments for you depending on this result that you just told us. Okay, doing your BRCA gene test will depend upon whether you have family history of breast cancer. So if your mom, your sister, your auntie, your grandmother has got breast cancer, then yes, we will tell you to go and do the BRCA gene test.
Is there any research on how sugar is not a cause? Because the surgeon that did my mother's cancer told us strictly not to take sugar.
Yeah, so again, as I said, there is no research either way to say that sugar does not cause cancer or to say that sugar causes cancer. I think this fallacy or fake news came about because we have a new scan called a PET scan, which uses radioactive sugar to light up the cancer in the body. Okay, so the PET scan is a CT scan, and it combines radioactive sugar, glucose, to pick up cancer cells. Now, it picks up the cancer cells because cancer cells are dividing very fast. Okay, everybody needs sugar. If you don't have sugar, you'll die. Okay, you need sugar. That is the basic fuel of your body. That's how your body works. If you don't have glucose at all, honestly, you will die. You will die of hypoglycemia. Okay, so the reason everybody is saying sugar is because of this new PET scan that takes up the sugar, the radioactive sugar, and that's why everybody says, oh, if you have cancer, you cannot take sugar. But it's fake news. Okay, there is no research to show that sugar feeds cancer. Okay, so it's very difficult to undo something that your surgeon has told your mother, but unless your mother is diabetic, she can actually have her sugar. What we're trying to say is that you should eat healthy, basically. Lots of fruits and veggies, you need to have all the various, the carbohydrate, the protein. Asian diet is actually very, very healthy. We don't eat chunks of meat. Okay, we have a little bit of carbo, sometimes a lot of carbo, and then a little bit of protein in not too much of it, and we have lots of green leafy vegetables that we enjoy. So I think Asian diet is actually very good. It's almost as good as Mediterranean diet. And I don't think your mother is going to enjoy either Mediterranean, and I'm sure she wants, if she's Indian, I'm sure she wants her rice and curry, and if she's Chinese, I'm sure she wants, all the things that you all eat. And therefore, my advice is basically just eat everything. You just need to moderate the amounts, and you need to moderate the things that I told you about burnt animal fat. That's it.
But Dr. Pat, when you talk about burnt animal fat, this applies to everyone. It's not just to people with breast cancer.
Exactly. It applies to everyone, not just those who have cancer. You should not be eating burnt fat, basically.
Yeah. So don't restrict the person who has breast cancer. The whole family should eat the same thing.
Yes, exactly.
So another question is, I am HER2 positive, going for targeted therapy, Herceptin, Perjeta, and Paclitaxel. Please advise, can I take COVID-19 vaccine at this time? If yes, which vaccine is preferable?
Right. So there are no definite guidelines about this. But if you're doing chemotherapy with the Herceptin and Perjeta, don't do anything. But if you're doing the Paclitaxel and your blood counts are low, so if you have if your white blood cell especially is low, you have neutropenia, then you should not take the vaccine. So your doctor will be the best one to advise you. Okay. During the chemotherapy, because taking the chemotherapy will drop your blood counts. If your blood counts drop and then you go and take the vaccine, you can end up in trouble. So usually we need to look at your white cell count before we decide whether we can give you vaccine. I mean, all the vaccines are the same. There is no vaccine that is 100%, but all of them give you immunity. And therefore, whichever vaccine is available, please sign up and take it. Because you're doing chemo, I think you need to wait and ask your doctor when it will be safe for you to take. If your blood counts are good, you can go ahead and have it, because you usually have chemo at 3 weekly intervals. So if your blood count is good before the 3 weeks are up for your next chemo, you could probably take it in between as well.
Is Taxotere, carboplatin, and Herceptin a strong medicine? How long does it take to recover?
The combination of this is Taxotere, carboplatin, and Herceptin. Well, they are all very good medications. There's no really such thing as strong and weak medicines. We give it to you because it has a very good outcome for those patients with the same type of disease that have taken these medications. Okay, actually, the TCH regime, as we call it, so that's the taxotere, carboplatin, herceptin, is actually a very easy one to get through. It's not so difficult. Okay, you really feel tired. That's the more. I mean, you're not really. You don't have much nausea, vomiting. It's a very well tolerated chemotherapy with Herceptin regime, and you actually recover very well. It's a very good combination.
What is the recommended time gap between Zometa jab and COVID-19 vaccine?
No difference. You can take it anytime. They don't affect each other.
I am 57. Can I still continue taking tamoxifen?
Yes, you can, but there are better alternatives. So instead of taking, so again, tamoxifen has the side effect of causing thickening of the lining of your womb, okay, of the uterus. And therefore, if you are taking tamoxifen, you should be seeing your gynae at least once a year to see the lining of the womb. Okay, if your lining is very thickened, then my advice would be to switch over to the better aromatase inhibitors.
Are roasted coffee, like our local coffee, and umami cooked food that is using high heat like char kway teow, should it be avoided?
No, don't avoid it. Just take it in moderation. Yeah, coffee is not animal, so you can carry on with the coffee, with roasted coffee. Okay, coffee is not an animal, and yeah, even the other one, even char kway teow is fine. As I said, you need to just moderate everything that you eat. You eat char kway teow every day. Of course, it's not going to be healthy, lah.
What supplements should a breast cancer patient take?
Actually, you don't need any supplements. Just eat normal food. I told you Asian diet is very healthy. Okay, don't waste your money on supplements. Keep it for a nice, good holiday because it has the same effect at the end of the day. It's placebo, which means like dummy pill. When we can travel, lah.
You can still travel in your armchair, Dr. Pat. Do chemo drugs like Red Devil affect our heart?
Yes, Red Devil is anthracycline, okay? And yes, long term it can affect your heart, but if that's only if you already have heart problems. If you're already hypertensive, you have some heart problems from before, anthracyclines can make it worse. But as I said, your doctor will monitor, he will do echoes for you. Echo is an ultrasound of the heart, and find out what is your ejection fraction before you even start, okay? And if your ejection fraction is falling during the treatments, of course he will stop the treatments or replace it with another chemo drug.
Should perfume be avoided by a breast cancer patient?
Definitely not. We want you to smell nice. Yes, please continue using your perfume. No difference at all.
So, Dr. Pat, every time you speak, I learn so many new things, and it's again a new learning experience. Thank you so very much for your precious time.
Most welcome,
We
Ranjit.
went
Most
like way
welcome.
beyond the time. Thank you
Yes,
so much. Would
my
you
pleasure.
give some concluding remarks?
Right. So for those of you who are breast cancer survivors, please make it a point to join BCWA. They do a lot for survivors. They're a fantastic advocate group. Okay, they actually fight for your rights. So please join them. Make the numbers more so that we have a bigger voice. Okay, and please do your follow-ups, okay, with your doctors. Please go for your follow-ups, okay. um, every year, at least once you've crossed 5 or 10 years, at least once a year, go and get your mammograms done. For those of you who are not breast cancer survivors, please go for your screening once every 2 years at least. And for those around you, since you are survivors, you must be advocates as well. Teach your daughters, teach your sisters, teach your mother how to do breast examination, how to examine their own breasts, so that they will know if there's something there, and encourage them to go for mammograms and ultrasounds after the age of 40. Yep, that's it.
Thank you, Dr. Pat. Thank
You're
you.
most welcome. Most welcome.